So, what we want to give an overcast of is the content of our life surgery course. This is a course which we are offering twice a year. It's strictly limited to maximum 8 surgeons who can attend life surgeries in 2 different theatres. I'm doing this course with Dr. Dan Del Vecchio, and we want to tell you a little bit about what we're going to transmit, what we're going to show in this course. The core part of our training course is safe fat grafting to the buttocks, which is currently a bit of a hot topic in plastic surgery naturally. This is also known as BBL, or Brazilian butt lift procedure. And I think it's fair to say that this has probably been the most rapidly growing procedure in the industry ever. It's got an enormous potential for body contouring practice and continues to be fueled by a huge social media hype, and it's got a great potential for fantastic results, which means great before and after pictures. On the other side, recently there's been a lot of publicity about safety issues with BBL, especially linked to intramuscular injection. Intramuscular injection is linked to the possibly fatal complication of fat embolism. And this has not been made any easier by the fact that due to the enormous growth potential of BBL, quite a few practitioners and clinics have started to get in that, which just have, let's say, a short-term experience and might not really know what they get themselves into. This is why we set to do out these courses. The cornerstone or the earthquake in the industry in handling Brazilian butt lift was this publication from Dr. Cadenas in Mexico, who was basically the first to point out the interest of the community to the possibility of fat embolism and BBL surgery. That really changed our view and our practice on that. However, to my personal experience, that didn't have much echo in the European patient community. However, this drastically changed, I think about 2 years ago. 2 or 3 UK patients were killed in BBL surgeries in Turkey with obvious incidences of fat embolism, and suddenly there was a massive awareness of the problem in the patient community. And I'm always confronted with a specific question, and patients ask me, "Look, doctor, is BBL a dangerous procedure?" Which I actually think is the wrong procedure to ask. This is like if you ask me, is it dangerous to drive a car? It depends on how you do it. Because what we strongly submit is that BBL, if done right, is actually a very safe and enjoyable procedure. There's just a few rules you have to follow, and there's a few technical considerations which can make your practice very safe against the incidence of fat embolism. And I've got a huge privilege that I'm friends with Dr. Dan Del Vecchio, who is the inventor of what we currently consider as bulletproof approach to BBL surgery, namely EVL. EVL stands for expansion, vibration, lipofilling. And in other words, that means that we do not inject fat with syringes into the muscle, but we use a continuous flow stream infiltration system with basket-type blunt cannulas and make sure we stay out of the muscle all the time. And then BBL becomes very safe. It's a bit tricky to learn, but it's really absolutely worth it. So this is the center part of our surgery course, to really have to transmit how you can safely do EVL fat grafting safe, not sorry. And there's a lot of stuff around, how to manage patients before the surgery and after the surgery, how to, and this is an important point, get maximum operating room efficiency, because you want to do this nicely, but you want to do this swiftly too, and not have your patients hanging in theatre too long, and a few pearls in post-operative management. Other surgeries that we're going to touch, we currently have a huge demand of surgeons coming to us who want to learn buttock implants. We favor a so-called composite or supercharge technique, combining butt implants and fat grafting. We do the same thing for breasts. We're going to show you something that we call dermal carving high definition, which is an approach to high definition lipo without energy-based devices, which I think is a great technique. and we want to focus on safe provision of makeover surgery. Now, when it comes to operating room efficiency, a few pills we're going to share, especially ultrasound mapping, which I think is a massive safety benefit and very, very swift to implement into your Brazilian butt lift practice. Hypothermia prophylaxis, a big, big topic and highly underestimated in operating room safety, cell-saving techniques, and the huge benefits of combination anesthesia. When you want to show somebody how to do BBL surgery safely, the first is to show him what not to do, and the first, what you must not do, is injecting into the muscle. However, to know where you're injecting, you must be sure that you've got control of your cannula tip, and the first step here is to avoid syringes, because you never really know for sure where your cannula tip actually is. EVL lipofilling gives you a great sense of security in that regard. Our practice in thinner patients shifts a little bit to buttock implants, because they're definitely bulletproof against fat embolism, and ultrasound mapping when you're getting yourself into that surgery, especially for beginners, a very valuable addition. Now, what we want to get into your practice is show you how to do a nice and very efficient BBL in a short period of time. That means you want a fat extraction speed of 100 milliliters per minute or more. You work with simultaneous fat collection and decantation. We strongly believe in a no-touch sterile circuit fat handling, and then re-infiltrate the fat with the same handpiece, just with a different cannula. And what we want to get to at the end of this is that you are able to do a good BBL surgery in 60 to 80 minutes stitch time. It should really not take any longer, which enables you to run it on a day case or 1 day stay, and it minimizes your patient recovery time. Now, one urban legend that we want to clarify is it's a frequent question I'm confronted with is, so you put such a large amount of fat grafts, and does that not increase the risk of fat embolism? And that is simply not true, because the risk is not related to how much fat you inject. It depends on where you inject it. So that means that the plane is the deciding thing. If you inject small amounts into the muscle, that can be dangerous. If you inject large amounts controlled into the subcutaneous tissue, that does not lead to fat embolism. So here the deciding thing is not how much, it's where. And what is super helpful to really get reassurance with this and to control this is cadaver dissections. I'm a great fan of these cadaver dissections, and you've seen these cadaver dissections exactly where, if I may say so, your enemy is, the exit point of the vessel. You know where you're going, and with the cadaver dissections, once you've done that, you understand that what you're seeing in this slide is what you absolutely do not want to do. You do not want to go with a syringe from underneath, under the convexity of the hemibuttock, because it is technically impossible to do that without passing at least through the muscle, highly likely injecting into the muscle. So whatever you want to take home, but don't do that. Don't come from underneath with the syringe. You can't control that. That can be high risk. Now, before we actually show you the continuous flow stream EVL injection, what we like to do before is the before mentioned ultrasound mapping. Ultrasound mapping, in other words, means that I'm measuring the thickness of the subcutaneous tissue under the skin, very comparable to a captain driving a boat, and the ultrasound mapping is my nautical chart, so I'm actually seeing what I'm getting to inject. It can be very, very helpful, because you're often amazed and surprised that thick patients may have thin subcutaneous tissue and the other way around. So that really is helpful to guide you how much cannula excursion you can actually have. And you see in this sketch, this is the philosophy. If you don't like bent cannulas, you can leave them straight. I like to work with curved cannulas, but the cannula moves in the subcutaneous space away from the muscle. And what you get is total palpation control. That means the idea of this is I move the vibrating handpiece with my dominant hand and with my non-dominant hand, I feel the tip of the cannula all the time. And since I've measured the thickness of the subcutaneous tissue, I know how much cannula excursion I can allow myself. This is something, and this is the part that I think you have to learn by feeling how fast you move the cannula, what is your intervals between infiltration and just expanding. This is why I see it's something that you have to learn tactile. You can't just learn from watching somebody doing this. Somebody really, I feel at least, has to show you that hands-on. And the same thing applies to the hips. This is what I call hip expansion or lateral fat injection. Aesthetically super effective to round out what people like to call the hip dips. And here the cannula goes into the subcutaneous space, the vibrating basket loosens up expansion element, and then you can inject safely with a continuous flow stream. Usually, start with 150, 200 milliliter an hour, a minute, sorry. But once you are more versatile with that, I usually go up to 300. And you see here, ultrasound mapping, you see the cannula there in the subcutaneous space. And you see very well demarcated the border between skin and muscle fascia, and this is the area that you want to graft. And what you want to have in the end is something that looks like this. You see here MRI pictures, clean, all the fat nicely in the subcutaneous space, and no marring of the muscle. So this is what you want to get to, and we want to show you how you can get to that and be safe, not sorry. So a quick reminder, point by point, how do we proceed with the lipofilling? Site prep, we measure the thickness with the ultrasound, great pearl for beginners. We prepare the fat by decantation only, no fiddling, no centrifuging, nothing that does not damage the good. Switch from a 5mm cannula for the tumescent infiltration to 4mm basket cannula for the fat infiltration. And when you start doing this, try to make sure that you do, let's say, half the time alternating expansion and infiltration. So you get a feel for this. And you see in the video here, you see the vibrating cannula. It vibrates with about 5,000 oscillations per minute. First you have a bit tumescent coming out of the tube, and then this kind of massage, the fat inside your tissue with the basket cannula loosening up the tissues at all times. And what is extremely important, to always have tactile control of your cannula. So I see the tip of my cannula with my non-dominant hand, I feel it. So that's the big difference of knowing where I am and just thinking where I am. So you can really control this very good with this technique. The famous endpoints, you see the old table videos, always looks very impressive. And it's fantastic to show to patients afterwards to keep them motivated, but never forget to advise them the volume that you see on the table, half of that goes down, which is about 25% of water resorption, 25% fat resorption. However, I think the efforts, as you see here, are very much worthwhile. Fantastic changes on the table, and this is why I think we all want to get the effort and keep this surgery a very feasible and safe one for a larger majority, because the possibilities for patients with this are really fantastic. And we insist that this can be learned, this can be shown, and banning something like this is the wrong way. You see here, the green versus the red line gives the idea or the parameter of success, which we call waist to hip ratio. This is what you want to achieve. Body feminization, a more female curvy shape. Another nice pearl that I'm also going to show you in the course is what we call anterior hip expansion, so they get the hourglass effect from the front. When they look into the mirror, that is has been an important advance for us to keep patients even happier with this. There's just a little reading suggestion, a paper that I did publish with Dan Delvecchio together in PRS December 2019 edition, giving you a kind of step-by-step breakdown how to handle composite or supercharged buttock surgery. And we're both very hopeful and confident that this will lead to a better acceptance of buttock implant surgery in both the patient and surgical community. Now, wrapping that up, you want to stay strictly subcutaneous and you will control that you're really there. The use of EVL This is probably the core of what we will transmit in the course, so you don't just see it but feel it and get an understanding of how to do it right. Ultrasound mapping, a great asset to our practice, and we will also show you as an alternative route the composite solution with implants and fat, if you don't just want to rely on fat, for those who are interested in that. And we're living in crazy times with COVID, but we are still very confident that we can celebrate our next course, hopefully the 21st, 22nd of September, and we would be delighted to welcome everybody to Marbella for that. Keep safe.